Good evening, everyone. Thanks for coming out. If you are here for an extra credit opportunity, we'll have the sign-in sheet for you at the end of the event when we're up here. So yeah, we'll go ahead and get started. My name is Akash. I'm one of the moderators for this event, and I want to thank you all for joining us this Friday for the 2024 Fall Semester Healthcare Roundtable by Universal Health Aid. UHA Cleveland is an undergraduate student organization at Case Western Reserve University that aims to address various aspects of healthcare access and health literacy through initiatives and collaborations amongst like-minded organizations. First, we want to take the opportunity to welcome our panelists who have taken the time out of their busy schedules to join us for this discussion. First, in the middle, we have Dr. Rose. Dr. Rose is a preventative medicine and public health physician and epidemiologist who has extensive experience in researching population health determinants and outcomes. He is a professor at the Case Western School of Medicine within the Center for Community Health Integration and the director of the Case Comprehensive Cancer Center Analytics Shared Resource. In addition, he serves as director of the Case Clinical Translational Sciences PhD program and Preventative Medicine Residency program at UH. His research interests include computer simulation models and data analytics to understand interventions, community-based research, and health economic analysis. And he focuses on cancer prevention and organ transplant allocation.
Thank you, Akash. Hi, my name is Claudia, and I'm one of the other moderators for UHA. And next we have Joyce Kim. Joyce is a medical student here at the Case Western Reserve School of Medicine, currently in her first year. She completed her BA in biochemistry from Claremont Mechanic College in California and is now studying an MD PhD program, which prepares physician scientists to work in clinical and translational research. She intends to get her PhD in pharmacology, and she has an interest in cancer drug discovery, specifically the use of immunotherapies for patients diagnosed with cancer.
And last, and certainly but not least, Dr. Mursky here is a physician who sees patients at university hospitals. After completing his medical training, he did his residency in internal medicine and followed that up with a fellowship in hematology and oncology. He now works as an oncologist at the University Hospital's Simon Cancer Center and Case Western Reserve University Comprehensive Cancer Center, specializing in thoracic and head and neck oncology. He's an assistant professor of medicine at the Case Western Reserve University School of Medicine and an associate program director for the internal medicine residency program. His research interests include health implementation science and tackling disparities in cancer care, and he focuses on increasing clinical trial diversity as a means to improve outcomes for African American patients.
So today, we hope to discuss cancer care from a variety of angles. Our discussion sections will include patient care, population sciences, and health disparities, public policy, and finally, screening and risk factors. We want to keep each section to about 15 minutes and encourage everyone here today to ask questions to our panelists following each section. So now that we've gotten to know Dr. Rose, Dr. Mursky, and Joyce, we would like to start off with a question about the respective backgrounds. To our panelists, can you each share a little bit about your journey, what inspired you to work in healthcare and specifically work with cancer patients, cancer prevention efforts, or oncology research? If you have any specific anecdotes or findings about how cancer has had an impact on communities in Northeast Ohio and Cuyahoga County, we would be happy to hear them in addition to what inspired you to follow this path. Whoever would like to start.
So, first of all, I want to thank you guys for having me. I'm really excited to be here. It's a lofty introduction. I know that I'll live up to it. But so, I'm from Maryland originally. I grew up in right outside of DC. And so my father was actually a medical oncologist in the 80s. He's a bit older, so it was a different generation. So Joyce talked about immunotherapies, like those didn't exist when he was practicing, right? So sort of growing up, I was exposed to cancer at a young age. I had an aunt who ended up coming to do the trial at the NIH Bethesda. So I was exposed to cancer care or cancer at a very young age. And I really didn't know, I thought about it, it wasn't really at my differential, right? So then I ended up going to undergrad, and then I went to get a master's in when I started thinking about what I wanted to do, first was to be a doctor. I sort of always wanted to be a doctor, was always interested in science. And then I went to Toledo for medical school and got to really work in internal medicine. From there, it really sort of took off. To me, it almost feels like, I don't know if anyone it reads Harry Potter here, but it's like the sorting hat where you sort of go and get sorted into your like tribe, right? Internal medicine is like my tribe. These are my people. We always connect in a very, very distinct way, right? So then and then from there I ended up doing my residency here, and during residency, I really wanted, I knew I wanted to specialize, but I also really liked a few things about oncology. One is obviously it's a very, very special relationship with our patients, right? We really are we're looked at sort of as we see our patients like every couple of weeks for their treatments. We get to work with them very, very well, and there's a very, very special relationship. So that was the thing I was really looking for. I also really like that cancer affects every organ system, right? So I'm not just working on the heart, or just working on the colon, or just working on the kidneys, right? I'm working on it. Every organ system is affected, so I get to sort of keep these foundational internal medicine skills that I really would worry about losing if I would sort of specialize elsewhere. And then I think I really wanted an outpatient job career, so working in a clinic was where I saw myself. So that sort of fit into it as well. And then I think finally, just spending time with oncologists, and you get to sort of see how you see these good outcomes, and it's really an infectious place, and I really felt great satisfaction. There's a second part of the question. Something about head.
Oh yeah, it was asking if you have any anecdotes or findings about how cancer has impacted those communities, specifically Cuyahoga County or just Northeast Ohio, based on your experiences.
Yeah, so some of my research actually looks into this. We looked at all patients who received immunotherapy. I don't know if you guys know what immunotherapy even is, but you probably see ads for Keytruda on everywhere. We looked at all of our patients in our university hospital system. So that's 14 counties. It's over 1,100 patients on immunotherapy, and we're looking at their outcomes, right? And what we're seeing is that patients treated at our academic sites are treated with an academic physician. By that I mean I do lung cancer, I do head and neck cancer. I don't do myeloma, I don't do breast cancer, I don't do glioblastoma. So there's an expertise, and everything is so divergent that when you're treated in a community setting, it's an impossible job to stay up on all these tasks, right? So I've decided that I want to work on just lung cancer and head and neck cancer, right? So patients treated in an academic setting like that, they do better, and I don't think it's because the academic physicians are brilliant or they're doing anything differently. I think it's because they're more likely to be enrolled in clinical trials. Okay? And we'll get into a lot about what that means later, but I think that our overall survival is actually better when clinical trials are involved, and I think that's one of the beautiful things that we have here with our consortium cancer center. Go right after this.
All right. So I didn't really want to be a doctor necessarily growing up.
Smart.
Yeah. Then I was kicked in the head by a horse. No, so I wanted to. I didn't really know what I wanted to do, but when I went to college, I discovered economics, and I really enjoyed that a lot. And I majored in it, and I thought I wanted to be an economist. So I actually, instead of going straight into a PhD after I graduated, I went to, I worked for a health insurance company, and in HMO, I did like pricing kind of stuff, and it was pretty interesting. But I knew that I really didn't want to do that, and I sort of getting more familiar with the healthcare system from that perspective. I started figuring out, I really do kind of want to do medicine. I want to treat patients, or so I thought at the time. This was the way I wanted to pursue medicine. But I wasn't a pre-med, so I got the Precedent Review book. It was $50, which was you could buy a car with that at the time practically. But, so I studied that and took the MCAT and did well enough on it, and then that year I took my pre-med classes and went to med school. So got out, matched in neurology originally, came up here was in the internal medicine program with Dr. Armitage, and then decided that I didn't want to do neurology, that actually I wanted to do more systems-focused kind of research. I was just always really interested in how, the parts of the system sort of come together to produce a whole, right? And understanding that complexity. So I went and got my PhD in epi and biostats here at Case. And then, I guess I worked at UH for a bit, and then did a preventive medicine residency, and then came on as faculty here at Case. And so I guess the thing about cancer that really interested me, I think I'm more of a methodologist. I like to build tools and platforms and models and things like that. But the thing about cancer that really interested me, and I guess the reason that's where most of my research focuses is, everything matters in cancer. Like from birth to end of life, right? We start out in differential risk environments, right? That affect our probability of getting cancer, right? We have differential access to being diagnosed in a timely manner for cancer. Differential access to time, to treatment, to culturally appropriate treatment, to all the way, all the way down. So across the life course, kind of there are so many places where outcomes can be affected, and I just found that really interesting and really, a rich environment to make a contribution. So I guess that's how I got interested in cancer.
My journey's kind of starting, but to get here, so I was also like Dr. Rose, where I did not think I wanted to be a physician. My dad's a physician, and I feel like physicians either tell you not to become a physician or they tell you to become a physician. And my dad was tell me not to go into medicine. But my aunt, unfortunately, had gotten to cancer pretty young when I was really young. And so I remember my parents trying to explain that to me, and it was something I couldn't wrap my head around. And so I did a lot of had a lot of questions about it. And so in high school and in a little bit of college, I wanted to get a PhD in cancer bio. And then I joined the lab, a radiation oncologist who was an MD PhD, and she did a lot of cool work where she took things that she saw in clinic or she learned in clinic, and then she would do research about it in her lab, which I think is super unique in terms of a standpoint that MD PhDs can do. And so that really inspired me to go more towards getting an MD PhD rather than a PhD. And then in terms of cancer specifically, so my aunt had gone under a couple rounds of chemo, and the cancer had seemed to disappear, and then the cancer had come back, and then she chose not to pursue chemo again just because she didn't think her body would take it. She mentally was kind of burnt out from cancer treatment, so she unfortunately passed away because she had chosen to do more palliative care in terms of her cancer treatment. And so that kind of goes into where I want to pursue research in the future, is to maybe create cancer drugs or immunotherapies that might be slightly less toxic to patients. That is my
Thank you so much for sharing more about your backgrounds. It's really interesting to hear your different perspectives, and we're really glad to have such a wide range of experiences on the panel. And I think some of us can relate a bit to studying for our MCAT right now. So, before we dive into our discussion on the prevalence, risk factors, and disparities that exist for cancer diagnosis, treatment, and screening, we hope to establish an understanding of what patient care looks like for those undergoing cancer treatment. To start our first section, I'd like to ask our panelists, what is a typical care journey for a cancer patient, from diagnosis to treatment and follow-ups? And what are some of the goals that physicians have when treating a patient diagnosed with cancer? And how can this process be different for each patient and the specific diagnosis that they might have?
So I can start with this one. And I think everyone's journey is different, right? So it's I'm going to generalize a little bit, but obviously everyone's going to be a little different. So generally, and hopefully everyone, in reality is that's the way the world works, but everyone has a primary care doctor that they see regularly, their USPSTF screenings regularly. So it doesn't work, that's not how it happens in the real world, but sure, let's say that's how this happens here, right? So I have a 20-pack year smoking history so I've smoked a pack a day for 30 years. I've now quit smoking. I'm getting a low-dose CT scan once a year, okay? Then on this low-dose CT scan, they find a nodule, right? It's maybe 1.5 centimeters, it's speculated, and say, this is interesting, but we need to evaluate this further. So they send me to a pulmonologist, okay? Or an interventional radiologist. They look at the imaging and they say, okay, the way this looks is concerning for cancer. They go and they do a procedure, either interventional radiology, where they stick a needle through between the ribs and sort of grab a little piece of it, send it to the pathologist, and then make the diagnosis. Or if it's more central, they'll do a bronchoscopy where they'll get sort of conscious sedation and then put a scope down your airway and sort of go to the inside and then some tissue sort of that way, send it to the lab. Okay? Then we get into, once the pathologist makes the diagnosis, say this is a non-small cell lung cancer. Okay. Then from there, the discussion becomes what is the stage. So then our patients will go through screening or scans, right? So for lung, you'll get a PET scan and an MRI of your brain. Cancers like this, lung cancer has a tendency to go to the brain, so you get an MRI of the brain too. You're then referred to either a medical oncologist, a surgical oncologist, or a thoracic surgeon, or a radiation oncologist. Okay. Generally, medical oncologists are the ones who are sort of quarterbacking this because in lung cancer, but it's different for each histology. From there, I meet them with a new diagnosis, right? And I want to determine what's the best plan. Is it a combination of chemotherapy and immune therapy and then go to surgery, straight to surgery, and then chemotherapy and immune therapy afterwards? Is it a combination of chemotherapy with radiation followed by immune therapy? As you can see, there's like 800 different ways to sequence this, but it's all rigorously tested, right? I have a discussion with the patients. The thing that I'm asking is, how do you define quality of life, right? What is quality to you, right? Are you someone who's important? Say, I have a wet. Say you have. First of all, our first discussion, we establish what our goals are. Are we trying to cure this cancer, or are we trying to control this cancer, knowing that at some point you will either die of cancer or with cancer? That's in my first discussion. Okay. Then if our goal is to control your cancer, okay, we're not trying to cure you. We have a discussion on what is quality for you, right? So like Joyce's aunt, she mentioned, she didn't want to go through more chemotherapy, and that's sort of the reason why that's sort of get in that discussion of quality, and that's how we figure these sort of things out, right? So from there, then we will go through chemo, whatever our treatment plan is. Every time, sort of assessing how it is affecting our quality of life. Someone who's, I want to be able to see my son who's in 9th grade, graduate high school. That's our goal, right? So we establish goals early on, and then.
I mean, Dr. Mirsky has the most, I think, informed sort of set of experiences in that regard. I mean, the only thing I would add is that I think it shouldn't be lost how protracted sometimes the time frame can be from you have a nodule to here's the plan, here's what we're going to do. And that can be an excruciating time, right? The other thing I think is just the practical impact of having cancer diagnosis on your financial security for a lot of folks. It can be devastating. I mean, it's controversial to say that think that medical debt is the number one cause of personal bankruptcy. I don't know if that's true or not, depending on the statistics you read. But certainly, medical debt is a factor in the majority of personal bankruptcies in the U.S. So, and there are just a lot of considerations around, people have to miss work, people, caregivers sometimes have to quit jobs. It's a big deal, and so the support systems around you matter a lot. So, we're really good in this country at treating cancer. We're probably better at treating cancer than treating anything in this country. We really don't do well at a lot of prevention and managing a lot of chronic disease, but we're pretty on top as far as cancer care. But I mean, there still are all these other things that get you to that excellent care, right? That differ for people quite a lot.
Jumping off of that a little bit. So when we go to present research at ASCO last year, presenting research, and one thing we do really well is rich, poor. We can get on Medicaid and we can get you your treatments, right? So people, from China, they say, oh, so everyone is getting these like thousands of dollars a month medications. That's like how we. Yes, here so we do well with the actual care. The financial toxicity is like an under-discussed thing that definitely deserves more on that.
And just to follow up, what aspects of a medical school education help prepare future healthcare professionals to support and guide patients through these journeys? We'd love to hear any personal experiences or thoughts about your training and your education leading up to where you are now.
It's actually a little bit ironic to me. Like we get motivational interviews, we got all of the didactic stuff in medical school about how to treat patients, how to have loads of care sessions. For me, I learned more. I worked as a bartender for a year before medical school, okay? And I got more out of that than I did working in research that I use to this day, right? Because at the end of the day, healthcare is like anything else. It's a relationship based. It's all relationship based. So when I meet a patient for the first time, I try to disarm them with this diagnosis because the word cancer has this scary aura, right? I tell them about myself. I ask them about their pets. I talk to them about their life because I want to disarm this anxiety or fear of cancer, right? Really, it's all relationship based. So I think yes, the reading or taking the motivational interview is one thing, but I think just talking to people, getting experience, talking to if there's a free clinic, like that to me was the thing I got most out of it, right? Going to free clinic and getting the reps, right? Of talking to people and working through experiences is really how you learn that. And then like I got more out of reading, being more alive to go on it, and probably did from the didactic in medical school on adult conversations.
Yeah, I couldn't agree more. I think a lot of what it takes to be a really good doctor to patients, you already know before you get to med school. It's sort of how you are and who you are and how you relate to people that matters. I mean, you'll probably have the experience, Joyce, of being told, by a patient or their family who's being seen by, a huge team of specialists. Each of those attendings has a trailing tail of fellows, residents, med students. But some family's going to tell you, you're my favorite doctor, you're the best doctor around, because because you spend time to talk with them, and you kind of comfort them, and you can know so much, but if you can't connect,
You got to make them feel like you're not a diagnosis, they're a person. They come in more than just they're not a T3N1 and N1A lung cancer. They're and from Ravenna who's got a pet named XY. That's who they are. They leave the clinic and that's their life. So
so you just went through block one. So we have in the case med school, the first block is becoming a doctor. Right? I think that's what it's called. And it's a lot about population health and social determinants of health, but it's sort of this time of really thinking a lot about that. So I don't know. I mean, I know your experiences are limited, but do you have any thoughts about like your preparation thus far for sort of the human aspects of medicine.
Yeah, I mean, kind of going off of what everyone said so far, I do recommend taking time off from undergrad. And at school, I took 6 months off and also worked a non-academic job. And I think it teaches you a lot on how to talk to people. In terms of the medical school curriculum, block 1 at CASE is becoming a doctor. It's like Dr. Rose mentioned, but it's a lot about learning about disparities that are present. CASE and a lot of med schools across the country also do standardized patient exams, like sessions you can call them. And one thing that CASE does is you do have to practice breaking bad news like cancer to a standardized patient. So if you're someone who might be a little awkward or maybe need a little practice, there are things in the medical school curriculum that does help you with that as well. And then block 2 is actually just a block I finished, and that was the cancer block. And they do bring in patients as well, who come in and talk about their journey with their physician. And so that is present in a lot of med schools as well. So you'll get to meet patients with cancer who are currently being treated for cancer. And they'll talk a lot about what it's like to go through the encounter as well. So that was really focusing.
Yeah, and then like jumping off that, right? You have a standardized patient, and the first time you tell someone they have cancer, it's gonna be awkward. You're gonna feel like you didn't do a good job, right? But I think that just getting the exposure, continuing to, that's why the free clinic is like a place where you get it. I mean, you're providing care for patients, but also you're getting sort of the reps and the exposure to really feel comfortable in your own skin.
Thank you so much for sharing. We're now opening up the floor to questions from the audience about this topic. Any questions about patient care or anything like that? You can raise your hand and we can call on a few questions. Otherwise, we can move on to our next section. So,
Long hours there. So just work with questions.
Yes.
What kind of experience did you have as a bartender that maybe helped you to success in that?
I think just being able to talk to people and being able to not even being able to enjoying just talking to people, you know, enjoying the getting to know somebody, which in my life now, yes, I have learned all of the underlying pathophysiology, XYZ, but again, connecting on a human level is really, and that skill was built from this working retail, working at a Subway. These are jobs that I've done. I've worked, when I was 16, working at a 9 cent bagels. This is how I learned how to talk to patients.
Yeah, as doctors are pushed to see more and more patients in a day, our visits are pretty good visits, 15-minute visits. How does that compromise the ability for a physician to make a relationship with a patient?
It's a great question, and I will sort of turn it on you in this way. It's not how much time you spend; it's how you make them feel. Okay. So my first visit, like I said, you'll read a note. I had with a social history to know this person, and so there's a few things, right? It's how you make them feel. So I get to know them as persons, and then it's a very comforting experience. And we feel like we connect, and we can cut through a lot of that in the 20 minutes that I have. And then there's just other approaches to the interview, to the patient encounter, right? I always sit down, and I'm always sort of either if they're in a hospital bed, I'm actually a catcher scratch because I think it's important that there's a sort of a patriarchal thing about it. I never wear a white coat. And again, as a white male, it's something that I really have the ability to people just assume that I'm a doctor. But I don't wear a white coat because I think it's important to sort of I have this patriarchal sort of I'm telling you what we're doing, right? I always go below their eye level because I want them to feel sort of on. So it's just these visual cues in the encounter. I sit down so I can then stand up, right? So you sit down to have this encounter, and then standing up is a sort of a social cue that, unfortunately, this encounter is ending. I need to move on to the next room, right? These are things that you can do to combat the shorter amount of actual time. It's really how you make them feel.
There's a lot of wisdom in that. I mean, there's a saying that people they don't remember in the long run what you say or what you know. They remember how you feel, and I think that's so true about medicine.
Thank you so much for your insight.
I think there was one more question. research side, as far as that goes, I think identifying and sort of looking at the underlying causes of disparities is sort of how I try to contribute. I do some, some cost effectiveness type modeling studies and things like that. And we're actually working on one. But as far as the
Kind of granular level.
granular level helping patients.
So Eliquis, blood thinner, right? The people we use this blood thinner called Coumadin for decades and decades and decades. It's you gotta change your diet, you gotta get tested 3 times a week to make sure you don't bleed out, right? Eliquis comes about 10 years ago. It's still under patent, but it revolutionized how we everyone who's got AFib, who's got a blood class, right? There's financial, so it's $600 a month, right? But there's ways to around it where you can get a free 1 month starter pack essentially from Pfizer. A 1 month starter pack, and then we have social work to sort of help get financial assistance before they have 30 days to get this financial assistance. And this is just an example of how we sort of get around that systems.
But if there's a whole, ideally there's a team in place in the hospital who helps navigate, that patient who helps them if they need to sign up for Medicaid, drug assistance programs, those sorts of things that happen. There has to be a robust system in place for that.
Yeah, so I really appreciate that you emphasize that cancer care is a very kind of heavy, gray connotation. And I also think that it's incredibly confusing and nuanced for many patients. It's kind of difficult to understand that cancer comes from, an individual's own body. So how do you go about kind of ensuring that the patient has the proper capacity to understand the diagnosis and what that means, in terms of treatment?
Yeah, that's a super question, and I think I'm sort of gauging health literacy throughout this entire encounter, right? I start by asking, do you know what a cell is, right? Because we use words and people assume that they know what a cell is. Like, do you know what a cell is, right? So it's really just it's starting at a low level, and I have a patient who's literate, right? So we talk, we get him supporting needs. I talk to him in a way that connects with him, and I assess his understanding sort of along the way. So like, what do you like? I was hoping you could sort of tell me basically play back to me what we're talking about, so I can sure. So it depends, right? So for instance, we had a patient who was not on insurance, right? So if you decided that we have support to get them enrolled in Medicaid, but if you are not on insurance and you sort of right away, there's safety net hospitals. So Metro, for instance, is a hospital. So we had a patient who needed chemo like that week, and so we just coordinated to get them over to Metro, which has a sort of safety net and financial assistance sort of from the state to sort of cover all of that.
But I think the big picture answer is there's not a great system. I mean, it's a safety net. It really is. I mean, it's a patchwork. There are holes in that net, right? And so it's very it's very labor intensive. It requires a lot of sort of knowledge of of what's available for people. It's a terribly intimidating system to navigate. I mean, I'm a physician, and it's hard to navigate, the system sometimes. And so I can only imagine how frustrating it is. And taking add on top of that some of the power dynamics and the past harms that have been perpetrated by the system. I feel sorry for patients who are having to deal with these issues.
So in like leukemias have a propensity for Latinos or Latin descent. So you don't. I have patients in Metro, they don't even speak English, they can sort of navigate this. They have this new diagnosis, so just think about how overwhelming this must be.
So sorry to cut off the questions, but I don't want to keep everyone here too late. We can, anyone can ask questions later on in this segment, but I would like to introduce the next topic. My name is Sachin, and the next topic will be population sciences and health disparities in treatment and prevention. So while a significant portion of cancer care involves medical care for patients, the prevalence of cancer also exists as a significant public health concern here in Northeast Ohio and across the country. For our first question related to population sciences and health disparities, I would like to ask that, according to research presented by the National Cancer Institute, certain socioeconomic factors such as race, ethnicity, geographic location, and income levels can widely differ from patient to patient and can be determinants of cancer incidence rates and deaths in a certain community. Would it be possible for you to share more about the connection between these factors and cancer? Some of this can be like, what are the impacts of these disparities from both a community and clinical perspective?
So I mean, we have data that shows that that these disparities really do make a difference as far as socioeconomic status matters, smoking status matters, exposures matter, race matters. These things all really do make a difference. And I guess the question is like, what caused these disparities? I think it asks more questions than it has answers, right? So is there something happening? I did some research in small cell lung cancer, which is a more aggressive variant, and we're looking and saying that air pollution exposure, you can look at the EPA's website by zip code and see what your air pollution exposures are, right? Is there a factor of the air pollution? This is just all an example. Right? But say I'm exposed to, I live in Haynesville and I'm exposed to these different carcinogens and I develop cancer. Is there something happening at the genomic level or even at the translational level where there's differences in the protein, overexpressing a protein being for cancer? We don't know yet. I think this is sort of the biological aspects of these disparities. I think that's really a cutting edge field in this.
I mean, just generally in this area, so we call the 15-county Northeast Ohio the catchment area for our cancer center. And generally in the catchment area and in Ohio, rates of cancer are higher for the U.S. Cancer deaths are higher than for the U.S. Particular standouts in terms of cancer are lung cancer, and particularly among black residents, particularly among black males. If you're a black male in Northeast Ohio, you have about a 50% higher chance on any given year of dying of lung cancer. Breast cancer, especially on Hispanic black women, significantly higher, not incidence, because a lot of times white women will get diagnosed with lower stage cancers that they may or may not have ever even manifested necessarily, but the mortality is much higher in non-Hispanic black women. Yeah, Dr. Marsky was right. I mean, it's very, it's complex, the chain of causality, right? But I mean, one thing's for sure, that risk factors run in packs, right? So they tend to cluster. A lot of the same folks who have, low education are the ones who smoke oftentimes. This is not my opinion. There's just data. Also, the ones who work in jobs where there's a whole lot of potential exposures, right? Deal with food insecurity, less access to immunosuppression in foods. So as you can imagine, I mean, these things, they're highly correlated. And the way that they interact to increase the risk of cancer death is complex. So it's hard, but we can say that, there are carcinogenic environments, right? And one of the biggest carcinogens is poverty itself, right? Because so many of those things hang with poverty.
And think about it this way, right? Like you work in a factory, you don't have a PCP, you can't take a day off of work to go see a doctor anyway, because guess what? That's like money that's going to food put on your table, right? So then you don't see a doctor, so then you end up missing and you get diagnosed later. What was I saying? This is all a pattern. It's like this all sort of goes together.
Yeah. I did actually took an environmental health class when I was in grad school. We had to do exposure histories on someone. So I did an exposure history on my dad, and I realized. So my dad, high school educated, truck driver, and this is the same story with all his brothers, pretty much everybody he grew up with. And I realized, my Lord, like, he was exposed to so many things. So he, that was a coal miner. If, when you were growing up in that period, you either went to the mines, the auto plants up in Michigan, or Vietnam. He did all three. And he got exposure, big time in all of those areas. In fact, he developed hairy cell leukemia in his 50s, I believe, which is linked to Agent Orange, which he had abundant exposure to. But I mean, there are so many things that I remember, like, well, he never went to the doctor. So he certainly never got screened. But he always had wounds, stuff like that, where he always had all of these exposures, And I think that's how it is with a lot of people. I mean, it's these things just sort of hang together, and it's a synergy of just very sort of carcinogenic behavior.
Thank you so much for your answers. I found it really interesting that you can discern these trends and socioeconomic factors using, case-by-case basis with Dr. Mercy, who treats patients one-on-one, and also Dr. Rose, who sees things sort of in the big picture as well. So the next question I would like to ask is, according to sources from the National Comprehensive Cancer Network, research shows that roughly 30% of patients undergo clinically significant depression or anxiety, yet only fewer than half of these patients receive mental health support. How can mental health practices be better integrated into med school training?
So into med school training?
Or as training overall to be a doctor, or even as a doctor?
So like the question being, how do we screen our med students for anxiety and depression essentially?
Well, it's more of the patients who receive cancer care that are undergoing this depression.
I think it's right. So I think one of the things that we do here as part of our cancer center, there has to be sort of all of this infrastructure in place. We screen everybody for anxiety or depression every single time they come to the doctor. The other thing is, I think, because medical oncologists are internists, we're internal medicine. I have the ability to have these discussions with my patients, and I can start them on an SSRI or refer them for therapy. I have that in my sort of toolbox, right? So I did that in residency, in your primary care experience. So I have that sort of in my toolbox. I think just recognizing and having that sort of being able to, I think it's I think we're doing better at in the last 5-10 years of recognizing this and sort of having the ability to have these discussions supported in place.
In terms of medical school education, we are taught that every time we do a patient exam, we're supposed to ask questions of them, like some along the words of like, have you been depressed, suicidal, or severely along those terms in the past week or so. And so hopefully, like when you shadow doctors or when you go to a doctor's appointment, you are being asked that question, even if you're being seen for something that is not related to mental health. So it's something that is being more incorporated into medical school, I think, now versus 10, 20 years ago. So.
It's very interesting to hear, like, all the way from med school to residency and even practicing and doing research, how we're providing a holistic cancer treatment that takes into account like patients' mental health is being improved. So thank you for this great discussion on health disparities and how we are tackling them. We encourage questions, but in the interest of time, we'll save them for the end. For now, we're going to move on to our third section, and this is going to be about public policy and systems impact. So more of the kind of policy measures that are in place. So having discussed the patient care journey for cancer care, as well as the disparities that impact our communities, we'd like to move on to our third discussion section. This is going to be about how health policy measures that affect cancer treatment for patients and cancer rates in the community are discussed and addressed. So.
Hello, my name is Edwin. I'll be presenting a couple of questions from this 2019 article from Johns Hopkins University Press on health systems affiliated clinics having higher odds of patient site follow-ups and just compared to private practices, which is all about disparities. So, given policy measures having impact on the decisions that can be made, we'd like to ask about what are the structural challenges within these facilities that might contribute to this disparity. So, like for instance, one of the examples that I had that got me thinking about the article from 2017 is that a lot of the low income and minority neighborhoods within Cleveland generally experience a higher rate of cancer-related disparities. So, one of the big things is that every now and then, like there's potential that people within these lower income lower socioeconomic settings may lack follow. That could either be financial issue, time-based issue, or just not feeling like they were valued in that particular facility. I would like volunteering in Painesville, and I get a chance to talk to a lot of people over there that are in the lower bracket regions, socioeconomic settings. I don't want to go back because I feel like I was not valued in that particular moment. So, what kind of policies can we do to change that?
So I think it's definitely a real thing. You're describing it. I think recognizing that we need to sort of meet our patients where they are. We need to make our patients feel valued. We need to really have them sort of express their understanding and sort of build a partnership with our patients, right? I think this is would also be great. Everyone is delivering care in their own way for patients, and I think just promoting a partnership rather than a program relationship where I say this is what you need to do, I'll see you in 2 weeks, right? It's about promoting that, and it starts at the medical school level actually. That's really where I think this all comes from. It's some of it could be a generational thing, but a lot of it is just, we get to start this early. We need to grow our physician workforce in a way that is sort of patient-centered. So it's really bottom line.
Yeah, I mean, it's a challenge because a lot of academic medical centers, there's a lot more sort of heterogeneity socioeconomically in the patient scene. And, some of the things we've talked about, just the logistical challenges, they're real. And, when you're working a job, a low-wage job, usually you're entirely replaceable. And you don't have the luxury of saying, I'm going to be a little bit late today. It's like, you're going to be fine, if you are. So that's really real. We did a study actually in the Buckeye Shaker neighborhood where we identified Buckeye Shaker, which is, you can stand on the center block and see it. It's just over there in the shadow of like these great most likely to face treatment delay if you live in that neighborhood in this area, right? For breast cancer, sorry, breast cancer. So we asked breast cancer survivors, their caregivers, providers, nurses, public health people, people from advocacy organizations about challenges, right? Getting care, which in this case related to timely treatment. Like part of that is the ability to complete follow-up. And there were sort of three things that were intrapersonal factors, things like fear and denial, fatalism. There were, more logistical factors, right? So literally just having to take multiple buses to get here, not being able to miss work, having to take care of other family members. That was huge as to why I couldn't get my care. $10 for parking, right? If you go over here and in park at the UH or the Cleveland Clinic, well, it's probably going up now. If you stay a while, you're gonna pay that. I mean, I know in some cases they have vouchers and things like that, but that's a big deal, and I think it sends a terrible message as well, right, to patients. So there are a lot of challenges, and then I'm trying to remember what the other theme was. I think it was more around support networks and the value of having support networks, and oftentimes it was those. It was everything but the physician. So, that really matter for getting them to.
Yeah.
I mean, if you can get to that, like you're going to get the world's best care.
Well, this is the thing, right? This is one of the things that we are blessed to be in this neighborhood. We're in Ward 6 right now. Okay, so 80% African American, 50% high school diploma or GED or less, 50% Medicaid, 8% completely uninsured, right? If our patients, we can get our patients to the clinic room, we can really, and so nationally, African Americans do where they when diagnosed with cancer, they don't live long. Right? If we can get them here, we can deliver this care that we're really proud of, and it's just about getting, like Dr. was saying, getting our patients to managing all these things. But it really has, to me, I see it as a really big opportunity.
One of the other things in that study, now I remember, was to just the interpersonal aspect around not feeling valued, right? Not feeling respected, feeling talked down to. And it wasn't just the providers, it was the entire experience, the culture, parking.
It's real. I hear it every day. No, I mean it. I hear it every day. Patients do not want to come because they do not want to. Right. They don't want to park in a garage, and they don't want to pay for parking.
We'll spend $200,000 a year on treatment.
Yeah.
But a couple of parking vouchers.
It's a real thing, right?
Outcomes will probably be better.
Yeah.
Thank you for sharing how policy measures can impact how we're providing care for patients that are trying to get into the medical care room and what we can do to improve that process. The CDC also reports that policies aimed at reducing smoking have been tied with statistics related to reduced lung cancer rates over time. What are other policy measures that you think would have strong evidence for effectively reducing cancer rates as a whole within communities versus the medical care side of things? How can we address these disparities in communities with policy measures?
I mean, about an estimated 26% of cancers, cancer deaths worldwide are attributable to smoking. 20% of cancers. So, smoking in America, obesity are huge risk factors for cancer. So, we can address those things. Now, can anyone guess what the most effective way to decrease smoking population growth. Not my opinion, evidence. Big guesses. That's it. Taxing. If you want to save lives, tax cigarettes. If you want to, if you want to save the healthcare system money and help people live longer, especially people who are low income and with low education, make cigarettes really expensive. It works, but doesn't. If you don't like it ideologically, that's another thing. But the evidence is pretty clear that it works. Also, get people tobacco 21 policies work, right? Where you have to be 21 to purchase tobacco, so increasing the supply in that respect, and getting people connected to care.
I think that was where I was going. Yeah, primary care is just a donut hole. There's not enough primary care out there. So increase for reimbursements, whatever. If we can get sort of more physicians in primary care and getting more access to primary care, I think really that is the big missing piece here.
I really appreciate everyone's insights on policies and impact in the space of cancer care. Once again, we will be able to provide, everyone here will be able to provide questions at the end of the discussion, just so that we can get more topics in a sufficient amount of time. Not everybody has to stay here though. So our next topic will be based on screening and risk factors.
So the two most common types of cancer in Cuyahoga County from 2016 to 2020 were female breast cancer and lung and bronchus cancer. Among other types of cancers, such as colorectal or bladder cancer, the efficacy of medical care for these two can be largely dependent on when it is caught, and that's dependent on screening. So, to introduce our fourth topic and the first questions within that topic, here's from
Yeah, thanks for the introduction. My name is Pranav. I'm briefing to answer that question in the first section. I'll be introducing our first question for this section. Just some context here. Accessible and consistent screening can help identify the incidences of these cancers early, which can improve treatment success rates. Our first question for this topic is going to be, what are the most common barriers to cancer screenings and follow-up care that hinder these communities from being informed of medical health? And how does improving access to cancer screening have an impact on cancer prevention?
The biggest barrier is primary care. Having a primary care physician. Like, how many people just raise their hand in this room have a primary care doctor? I would say that's well over the average. Still very educated and plugged in the community that we're in right now. But yeah, I think in general, primary care is the challenge with getting primary care. It is a huge thing, though, a huge barrier, right? If I can't see a doctor to assess for his medical history, I cannot get a liver screen. That's never gonna happen, right? So I think it's frustrating because it is a fix that is right in front of us. We just have to figure out how to do it.
Yeah, insurance, it really matters. Since the Affordable Care Act, almost every insurance requires screening for breast, colorectal, cervical, and lung cancer, because it's shown pretty conclusively if you catch those early, in an earlier stage, you can improve mortality.
And it's not even the insurance companies like being kind-hearted. It saves them money too.
Yeah. We did a study. It was in cancer in 2020, I think, where we looked in Ohio at low-income population and showed that comparing the 3 years before and the 3 years after, and the expansion of Medicaid in Ohio, which under the Affordable Care Act covers now up to 138% of the federal poverty level. That diagnosis of metastatic cancers that were screening amenable, those cancers dropped by 15%. So it really matters. That's not the whole story, though. You have to get screened, and you have to do something about it, right? And sadly, like a lot of there are multiple ways to get screened for colorectal cancer, and a very high percentage of people, it's approaching a third, I believe, of people who have a positive stool-based screen for colorectal cancer don't follow up with a colonoscopy, right? So you have something on your stool-based test that says you need to get a colonoscopy, and they don't get it, right? And similarly with a mammogram, we can have an ambiguous finding or a suspicious finding on a mammogram, and you may or may not get in for whether it's the MRI, biopsy, or the ultrasound, or whatever. So it's not always because they just are in denial or don't want to. Sometimes those things aren't always required to be covered by insurance. I mean, they are covered, but not for scholarship. The screening you should have to pay nothing for, but that doesn't mean that the follow-up diagnostic testing that you don't have to pay is significant.
Thank you for those answers. How can we increase awareness of screening programs? And a lot of us here probably need help going into healthcare roles. How can we increase awareness of screening programs, in our roles within healthcare? And what role does the media play in the stigma surrounding screening access?
So I think it's hard for any one person to change the screening, right? I think, like I said, if you go into it frequently, because these are probably most patients who are most likely to not be screening. So just inform everyone on the trip what the screening guidelines are, so know that people, if you ever go this one time every clinic, and then that was the second part.
What role does the media play in the stigma surrounding screening access?
I think that the media that I at least think that you tend to at least be talking about screening, and you see in the local news there's always screening. The Browns game was a whole thing. This is colorectal cancer, this is prostate cancer, so get screened. Yeah. So I think the media does make an effort.
It can be hugely influential. Remember Kate Couric? He posted the Today Show. So there's something called the Kate Couric effect. Her husband died of colorectal cancer, and so she became, really an activist around colorectal cancer screening. She got a colonoscopy on live TV, and after that, colorectal cancer screening really shot up, and it no doubt saved lives. But actually, we do all right in this country when it comes to screening uptake. Cervical cancer screening rates, generally are above 80%. Mammography rates generally are above 70%. Colorectal cancer rates, screening prevalence, in other words, if you're age eligible for screening, getting screening. That's not perfect, but it's pretty good. It certainly needs to be better. But the thing that we're just terrible at, I think generally in this system is preventing that cancer. And once we catch it, getting that person from the initial signal of, hey, this might be cancer, to getting them to appropriate care, right? It's manageable for them in terms of all the other things that they have to do with.
In terms of the medical school level, we are being taught about insurance quite early in medical school. I don't know if that was a thing you all went to.
I had that, yeah.
it still exists that we are learning about like insurance, and it is like very like we learned about in Block 1 for kids. We learned about like the Affordable Care Act and about I don't know, was it the person right next to me, you guys? But yeah, it's I think most med schools across, I think all med schools across the country are looking at things like that in their curriculum. So hopefully doctors and physicians will be more aware of that now will lead to better outcomes in the future.
Yeah, I know answers it. Thank you very much for your responses. I really appreciate that. Last question of the discussion today is going to be about AI-driven imaging, which I'm sure is like a huge part of healthcare and the future of healthcare. How emerging technologies like AI imaging influence the overall approach to cancer screening? Easier, harder, like I said that.
So I actually don't know the answer to that question. I mean, they go head to head, right? Like AI versus radiologists, and I think you're looking at diagnosing nodules. And I don't know if I actually don't know the data if AI is better than I think it's probably typical. It depends on the study.
Yeah, I mean, I've seen studies. I mean, in pretty controlled environments, AI can often pick up. It can often be more sensitive than a human reader. So it can pick up things that a human reader might miss. However, it can also pick up things that aren't there, right? So it can have false positives. So that's a problem. I mean, the same thing. So lung cancer screening and breast cancer screening are done with radiologic studies, whereas cervical cancer screening tends to be done with pathologic studies. So we look at either one will look at images, and in fact, colonoscopy. There's now AI-aided colonoscopy in real time. It'll, it's almost like Top Gun or something. So the bogey lights up, red. There's that suspicious bubble, and it's pretty darn good. But yeah, I mean, I think that it's still early, and I think that the consensus is that it's a good adjunct, but certainly we're not ready to toss the keys over. And the other thing, AI in medicine in general, not just in medicine, but the data you train on really matters.
But it matters.
Yeah, and the data that we train on is not always representative of the full population, right? So there's really the potential for biases to be baked right into the algorithms. Okay, so definitely something to touch about. But I think it's I think it's going to really change. It is changing radiology for sure. It's really going to change pathology. It's going to change a lot of things, or anything where you have to have a. I have a PhD student, really smart guy. He's developing basically an algorithm that runs on a wearable device that is like a continuous detector for sort of like epileptic waveforms in EEG. It's really cool. He's training this model to read EEG, basically has a bit of neurology studies. So yeah, I mean, it's gonna be a huge player. It's never gonna take the place of coming out your pets.
That's right. I also mean this is a plug too. Whenever when you all are physicians, don't just look at the reports. It's really you get a lot from looking at pictures.
I can tell you an anecdote without divulging any serious details, but there was an AI read image at one of our local healthcare institutions that the radiologist did not properly check when it read a fracture in a child, and that led to county services being called on the family over abuse. It was a good fracture. That's a human error. for sure, but it just goes to show you cannot rely, you know, just toss the keys to the island.
Thank you very much. Yeah, I've had a lot of conversations with my friends who are a lot of comp sci majors who talk about AI and how much it's helpful fields of anything really. Any other questions in the audience? Stay after. We're all going to be looking for at least a little bit, but this is going to conclude our discussion on how we can advance cancer care in local communities and clinical practice. On behalf of UHA, Cleveland, and all those who helped organize this event, and the audience, thank you guys very much for coming, and thank you all of you for your time today. It's been a very good experience.
Yeah, thanks for having me. It was a lot of fun.
We'd also like to offer our sincere appreciation to our panelists for their work in med school, the hospital, the community, and research to improve the lives of patients and members of Cuyahoga County and this country. Their work in patient care, alleviating health disparities, and doing meaningful research